Welcome, everybody, to the GU Pathology virtual education session on adrenal pathology. Today, we have two wonderful speakers. We're delighted to have Dr. Oscar Mete as our first speaker. Dr. Mete did his initial medical and residency training at Istanbul University, followed by fellowship training in endocrine pathology under the mentorship of Professor Sylvia Asa at the University of Toronto. He joined the faculty at the University of Toronto in 2011, where he has received numerous awards for teaching. And he's currently appointed as a professor in the Department of Lab Medicine and Pathobiology, and also serves as the Anatomic Pathology Residency Site Director at the University Health Network. Dr. Mete has published over 240 peer-reviewed journal articles in endocrine pathology, and he's also currently the editor-in-chief of the Endocrine Pathology Journal. Importantly, Dr. Mete served as the lead author for several chapters for the fifth edition of the WHO classification of endocrine and neuroendocrine tumors. And today he's going to speak to us regarding important WHO updates in adrenal pathology. And just as a quick housekeeping note for everybody listening in, please type in your questions into the Q&A box at the end of both Dr. Mete's and Dr. Sado's talks today. Dr. Tretiakova and myself will moderate the questions. So without any further ado, I'll let Dr. Mete start his presentation. Thank you again.
So everyone, welcome again, and thank you for the great pleasure to be here today with all of you. Although this is a virtual educational session, we will try to provide our enjoyable practice of adrenal pathology with Peter today. So again, thank you for the GU Pathology Society educational team to organize this session. So I was asked to present in roughly in 25 minutes the 2022 WHO updates in adrenal pathology, which will include the adrenal cortical pathologies and as well as adrenal medulla related findings. So I have nothing to disclose. And the learning objectives is basically, I will try to highlight some select topics to emphasize the diagnostic entities and nomenclature or taxonomy changes in the new classification. And I will try to hopefully justify or provide some additional clarifications on the concept of the adrenal pathology, similar to other fields in endocrine pathology, is not just H&E anymore. So we combine structure and morphology correlations with biomarkers to enrich and to strengthen our diagnosis to be useful in the clinical management of our patients. Therefore, there will be lots of component to the role of ancillary biomarkers, which may or may not available in some practices, but at least we will try to define what is potentially more desirable or essential. So let's start to the journey or to the new classifications or to the updates in adrenal cortical pathology. Potentially, the most significant updates in the WHO 2022 of adrenal cortical proliferations involves the refined classifications of what we refer as right now adrenocortical nodular disease, which now includes a new entity called sporadic nodular adrenocortical disease and already known bilateral micronodular adrenocortical disease, and also formerly known hyperplasia or micronodular primary adrenocortical hyperplasia is also now called as bilateral micronodular adrenocortical disease. So basically, this entity or this group of entities have been refined in the new classifications. Among these, I selected to discuss mostly the novel entity of, or the new defined entity of sporadic nodular adrenocortical disease as per the new classification. So these are actually what we discovered as an incidental, usually sub-centimeter, non-functional adrenocortical nodular proliferations. They are usually solitary or unifocal, but they may be sparsely distributed in terms of multifocal manifestation. You can find them in the radiological imaging studies as incidental small cortical nodules. They may be bilateral in 5% of the imaging studies. So basically, the reason why we define this entity is because of the fact that most of these nodules, when they reach a size of as small as 3 millimeter, they become a clonal neoplastic disease. And sometimes these are of interest for understanding germline predisposition of some of the patients. Sometimes they are relevant in terms of, is this a functional or non-functional disease, and how are we going to term them? So the most important thing from here, anything sub-centimeter that is functional is actually a neoplastic disease, and it's also an adenoma or microadenoma. But these are called right now, the non-functional sub-centimeter proliferations are now called as sporadic nodular adrenocortical disease. Another important highlight from the new classification is the structure and function correlation, which is essential in endocrine pathology practice, or in endocrinology, in other words. Pathologists have used several ways of assessing functionality of an adrenocortical proliferation. Beyond the clinical history and the laboratory testing, we have the tool that is still available as the morphology that help us to distinguish which adrenal might have a suppression of the excess cortisol, which is reflected in cortical atrophy in the setting of adrenal Cushing disease, or in the setting of a spironolactone therapies, aldosterone-producing sites will have spironolactone buddies depending on the time frame that the patient was subjected to this therapeutic approach. In the past, in the old days, pathologists have used ultrastructure examination to distinguish aldosterone-producing cells from a cortisol or non-functional or steroid hormone-secreting cells based on the anatomic morphology of their mitochondria. So basically, this is no longer required because we combine right now the traditional H&E and also functional immunohistochemistry. And among this steroidogenic enzyme immunohistochemistry, you will see that potentially these are desirable for all cases, but it's potentially coming more and more essential towards the directions of primary aldosteronism with respect to CYP11 beta-2 immunohistochemistry. So let's discuss a little bit morphology. The cheap, but still very valuable morphological assessment of adrenal cortical atrophy is based on the reduced adrenal cortical thickness. Reduced thickness means less than 2 millimeter, and which is usually associated at least with intermittent loss or absence of zona reticularis layer. So of course, this is a typical example of a cortisol secreting or glucocorticoid producing adrenocortical adenoma, where you can easily see that the cortex is atrophic, whereas in the setting of a primary aldosteronism-related aldosterone-producing adenoma, you don't have any cortical atrophy. And the same thing is valid for sex steroid-producing neoplasm or non-functional tumors, which will not have cortical atrophy. So always check the non-tumorous adrenal cortex, because sometimes clinical texts may miss, clinical investigations may miss subclinical Cushing. Primary aldosteronism is potentially the area where the functional immunohistochemistry is playing or is going to be more and more available for pathologists for their workup, because of the fact that primary aldosteronism or aldosterone excess can be sourced from a single lesion, which can be microscopic, as in this case, or in other cases, it can be related to a large tumor or a smaller tumor without additional microscopic disorders, which may predict a bilateral disease, which will not be detected on imaging or at the gross examination. This is the type of specimens that pathologists are required to submit the entire specimen if they don't see any grossly visible nodule, and ideally the entire adrenal specimens, adrenalectomy specimens, should be submitted from the cortex in patients with primary aldosteronism. Given the challenges associated with the detection of the sites of aldosterone excess, experts have defined some practical approach to define all this microscopic disease, or maybe this is a decoy lesion which is not responsible for aldosterone excess. Maybe something here is responsible. And if these are multifocal, this patient is at risk of having bilateral disease. For this reason, the Histado classifications has been developed back in 2020, 2021, and it has been endorsed by the new classifications as a desirable approach for the workup of adrenal specimens from patients with primary aldosteronism. These classification schemes combine morphology with the CYP11 beta 2 expressing lesions to define 6 categories of entities, which is the first one is the odd carcinomas that are linked to aldosterone excess. But if we put this one aside, we have uh, basically 3 main lesions that can occur in most specimens, which is aldosterone-producing adrenocortical adenoma, aldosterone-producing nodules, sub-centimeter lesions that are morphologically visible to our eyes, or aldosterone-producing micronodules, again, sub-centimeter, usually wedge-like smaller lesions, which may be difficult to see on H&Es if you are not trained to see them. And the multifocal disease, which is an atypical histology, that will actually alert you for the possibility of a bilateral disease, because patients with multifocal aldosterone-producing nodules and or micronodules have been identified in lack of biochemical cure in around 42% of the studied examples. And also, although they should not come to our surgical pathology practice, patients with diffuse hyperplasia will be associated with biochemical recurrence or no benefit from a surgery, because these are the type of patients that will require lifelong anti-mineralocorticoid therapy. So basically, the combined approach, combining structure, morphology, and also the immunohistochemistry, help us to define the atypical 2 categories from less recurrent, or let's say the less risky population. Let's see some of the visuals. Here's an example of an aldosterone-producing adenoma that is highlighted with CYP11 beta 2 immunohistochemistry. This patient did not have any additional CYP11 beta 2 expressing and nodular proliferation, and it was cured after surgical resection. Unlike the aldosterone-producing adenomas, where you don't have CYP11 beta 2 showing a gradient staining, both aldosterone-producing nodules, which are morphologically visible to your eyes, and also micronodules, which may be difficult to distinguish on H&E stain sections, they will have what we call gradient staining. They have reduced staining on their lower part or closer to the inner part of the adrenal gland. Here's an example of a difficult case where you can appreciate that these little microscopic foci may be easily missed, and some of the eyes cannot be even distinguished those multifocal aldosterone-producing micronodules, which explains why some of these patients, in around 42%, have symmetrical or asymmetrical recurrence of their disease. Here's another example of where you have a combined diffuse hyperplasia, which is more than 50% of the adrenal cortical zones being affected with CYP11 beta 2 expressing linear proliferations, which may have as well additional micronodular proliferations. So these are the things that we are targeting and distinguishing from a solitary lesions in order to call the risk. So let's move right now to the malignancy. What is new in the diagnosis of adrenocortical carcinoma? I will rephrase this. From a morphological perspective, there's nothing novel, because we are still doing the same approach. We are still counting mitosis. We are still looking for the right vascular invasion, but we are submitting the periphery of the tumor in patients where we don't see the vascular invasion, because the new classifications underscored how important is, as a diagnostic and also prognostic variable, the identifications of vascular invasion. because low-grade adrenocortical carcinomas confined to the adrenal glands, if they don't have vascular invasion with low proliferation index, they are not recurring in significant proportions of the situation. For instance, a low-grade ACC with vascular invasion can come back after even 22 years later of the original diagnosis. Therefore, we have to do our due diligence to hunt for vascular invasion, to count properly mitotic activity, to determine other risk parameters such as tumor necrosis, extra-adrenal tumor spread, and also atypical mitotic figures. But the new classifications place an emphasis on the role of ancillary tools because some of the time we have inter-observer variations on what to call a mitotic activity or what to distinguish a vascular invasion. And there are tools for us to alert us to say, this is not a garden variety adrenocortical neoplasm. So these ones we're going to discuss in a moment, but the current classification recognizes histochemistry, immunohistochemistry, and molecular testing as a part of the diagnostic workup. This is a busy slide that summarizes as well the available, up-to-date, potentially classifications or multi-scoring systems that are being used in the field of adrenocortical pathology. The new classifications allows user, us as diagnostician, to use reticulin algorithm, which is a very cheap and easy way of assessing adrenocortical cancer, and also the Helsinki scoring system in adult adrenocortical carcinomas, and also in oncocytic adrenocortical neoplasm, in addition to Lin-Weiss Bichelia system. After the WHO, there has been some updates on the pediatric adrenocortical neoplasms, where the users are now able to apply with some restrictions, the reticulin algorithm, the Helsinki scoring, but we need to have a little bit more evidence and reproduce data. So I encourage everyone to work on this similar projects for us to add some value in addition to Beinecke or FIP classifications for pediatric adrenocortical neoplasm. So let's discuss the cheapest approach, which is potentially available in every single pathology lab, reticulin histochemistry. I can't emphasize how useful is this parameter or this algorithm when you have any doubt, because most of the time, the high-grade tumors, as long as you define their adrenocortical origin, it's an easy call. So reticulin histochemistry allows us to detect the abnormal alterations, such as in most of the time, loss of reticulin framework, which is a finding in carcinomas, but it has to be away from site of degeneration. That's very important. And also a combined loss and mesh-like abnormal pericellular pattern in association with either necrosis or increased mitotic activity, which refers to more than 5 per 10 millimeter square, or angio invasion, would qualify for a diagnosis of vascular invasion. Among biomarkers that have been defined, the most reliable one is the IGF-2 immunohistochemistry. When it is optimized at high precision to detect these abnormal molecules, heavy molecules in Golgi region, at 1 in 3,000 to 1 in 6,000 dilution, you can render a diagnosis of an adrenocortical carcinoma. This is actually opening the door for core biopsies to be used for the diagnosis of adrenocortical carcinoma, but it doesn't exist in all adrenocortical cancer patients. So basically 75 to 80% of the cancer patients will have IGF-2 overexpression. When you need it, they are not useful, but when you have an obvious case, of course, p53 and beta-catenin abnormal stainings are useful towards a malignancy. Not necessarily that diffuse nuclear beta-catenin will indicate a malignancy, because a subset of subclinical Cushing patients and also non-functional adenomas can have WNT pathway alterations. But the Ki-67, which is typically over 5% in most adrenocortical carcinomas, is a reliable way of assessing things. And there's more and more evidence that if you have 15% and over, it is likely an adrenocortical carcinoma. Of course, the diagnosis of malignancy can be rendered using transcriptome analysis because we have right now tools that can distinguish adenoma from carcinoma and also can help prognosticate the tumors. And in addition to this, of course, methylome studies have been shown to detect or distinguish carcinoma and also prognosticate subgroups. But of course, these are not widely available or covered in all practices. And these are, of course, desirable things to do, but it may be more available in the near future. The other things to discuss in the new classification is we don't have actually a Ki-67 based grading system. We consider Ki-67 to be a continuous variable, and each adrenal cortical carcinoma patient should have a specific number assigned, nothing like less than this or beyond this limit. It is important to know what is the exact percentage of this proliferation index, and by selecting hotspots, because from blocks to another block, you can have variation easily. But one thing that we still kept in the classifications is the traditional, well-accepted WISE mitotic tumor grading, which is based on the cutoff of 20 mitosis per 10 millimeter square to define low and high-grade disease. Whether this cutoff is valid or not, this is a separate discussion at the academic level, but this is a required element for reporting of adrenocortical carcinoma. But if you forget everything, don't forget to confirm adrenal cortical origin. And this is the most common mistakes, at least I have seen in 1 in 10 adrenal consultations that I'm seeing. Tumors that are labeled as adrenal cortical carcinomas are not adrenal cortical carcinomas. So the SF1, steroidogenic factor 1, is the most reliable immunohistochemical tool to confirm the cortical origin. But if you don't have access to this, and if you have non-specific biomarkers, do them in a panel. Try to get SF1 in your lab, but don't forget the synapto and alpha inhibin can also be expressed in a subset of paragangliomas and pheochromocytomas. So with this time, I will have a limited time to discuss the pheochromocytomas or intraadrenal paragangliomas, but I will highlight the key points for the practicing pathologist colleague. So both of these entities, like both paragangliomas or intraadrenal paragangliomas that are termed as pheochromocytomas, represent the same disease from a classification perspective. These are non-epithelial malignant neuroendocrine neoplasm with metastatic potential. There are no clear-cut morphological features, reliable morphological features that will tell which tumor will metastasize. But these are similar to other neuroendocrine epithelial neoplasm. Therefore, the new classifications still preserve the concept of malignancy or the concept of having metastatic potential in this neoplasm. More importantly, in addition to general neuroendocrine markers such as INSM1, chromogranin A, synaptophysin, and their negativity for keratin immunohistochemistry, the specific markers to confirm the paraganglia or the pheochromocytoma diagnosis is not the chromogranin A. You have to combine the enzyme immunohistochemistry along with transcription factor expressions of this tumor. And the two transcription factors that have been useful in this setting is GATA3 and the recently defined FOX2B. And I'm happy to say the third one is also coming. It will be published soon in our journal in endocrine pathology. And please follow the publications. And the tyrosine hydroxylase is the rate-limiting enzymes in the catecholamine biosynthesis. And when the tumors are functional, they are very useful, but in non-functional tumors will not have this. This is why we have to combine in certain conditions these two biomarkers. There are also additional novel biomarkers that are desirable in the functional assessment. And for the sake of pheochromocytomas, dopamine beta hydroxylase can help you to determine if your tumor is making noradrenaline and if there was no preoperative biochemical testing. But one of the unique features of PHEOs or paragangliomas is the fact that these are highly inherited human neoplasm. And depending on their anatomic locations, in the adrenal, it's around 30 to 40% in adults. But in general, if you go to paragangliomas in the thoracic and head and neck region, at least 1 in 2 patients will have germline disease. So we are dealing with a field that is very unique, and almost 1 in 3 to 1 in 2 patients typically show germline pathogenic alterations. And what we have learned from this disease is we can actually predict potential genomic clusters by checking the preoperative catecholamine levels of these patients. For instance, patients that has no adrenaline excess or no metanephrine excess, they are being named as immature catecholamine secretory phenotype. Either they can have pure dopaminergic or dopamine and noradrenaline, or pure noradrenergic. These are not the patients that will have red neurofibromatosis, or what we call cluster 2 disease. So basically, presence of adrenaline and no adrenaline makes a huge difference, because patients with immature phenotype are prone to have frequently ASTH mutations in the adrenals. So in adrenal paragangliomas, or so-called pheochromocytomas. So basically, we have also tools to predict the germline susceptibility in this disease. And the way to do this is we combine still morphology of some harbingers of VHL or ASTH, or the presence or absence of adrenal medullary hyperplasia, or the presence of multiple tumors in the same adrenal, or the presence of bilateral adrenal pheochromocytomas without composite elements. But basically, the morphology, it has limitations. We combine them with biomarkers, and of course, the molecular testing is useful in this distinction. For people who are practicing GU pathology, you guys are much more familiar than most endocrine pathologists with respect to FH or 2-SC immunohistochemistry for fumarate hydratase deficiency related tumors. But more importantly, STHB immunohistochemistry is an important tool for us to distinguish STH deficient pheochromocytoma. But if you know the tumor has adrenaline excess, you don't necessarily need to do STHB immunohistochemistry unless the patient has RET and additional variant of uncertain significance, STH pathogenesis, which is an unusual features. As I mentioned earlier, alpha inhibin can be expressed in paragangliomas and pheochromocytomas, and this is typically related to cluster 1 disease, where the pseudohypoxic pathway is involved. And here's an example of an ASTH deficient paraganglioma with dopamine and noradrenaline excess coming from a pheochromocytoma, and alpha inhibin was variably positive in this tumor. Of course, we don't render a diagnosis of STH deficiency based on alpha inhibin, but it is a pitfall or a screening of the pan-pseudohypoxic pathway. These tumors, STH deficient tumors, have a unique morphology, but the diagnosis of deficiency requires a good quality immunohistochemistry that shows global loss in the tumor and positive intratumoral endothelial positivity, which is your internal control. This means a lot for patients who don't have germline testing yet, or patients who have a variant of uncertain significance of one of the ASTH genes. VHL-related tumors are frequent depending on your practice area, and they have a unique morphology, in my opinion, but it's not specific to VHL, but I will say HIF pathway-related, non-Krebs cycle cluster 1 disease. They typically have thick vascular capsule with stromal degeneration, edematous vascular stroma, and also this glassy or clear cell, or sometimes oncocytic cell morphology. And of course, there are 2 markers. Your alpha inhibin can still be useful in a subset of the cases, but it will not be distinguishing the specific underlying pathogenesis. But carbonic anhydrase membranous diffuse positivity is regarded as a reliable markers to suggest either somatic or germline VHL-related pathogenesis. Adrenal medullary hyperplasia is also an important morphological harbingers of a germline disease. This has been a characteristic features of a RET-driven pathogenesis, but it can be seen in other cluster II disease, such as MAX or transmembrane 127 or neurofibromatosis event, but it is also be present in a subset of ASTH-related pathogenesis. But what the new classification has defined or refined in this era is there's no longer nodular adrenal medullary hyperplasia. All these distinct nodules are now called as microtumors or small microscopic pheochromocytomas or micropheochromocytoma. And when you have a diffuse expansion of the adrenal cortex, adrenal medulla, which is supposed to be 1/3 of the entire cortical thickness, is a sign of hyperplasia. And look at this, even here you have a vague nodule, which is likely small nodules. And this was a patient where I detect these pictures. You can appreciate the another microtumor in this slide. So my few last remaining slides emphasize how important to deal with the distinctions of metastatic disease when you have a few chromocytomas or extra-adrenal paraganglioma, because you are dealing with a highly inherited disease, highly heritable disease that is prone to develop multifocal primary tumors, either synchronous or asynchronous. For this reason, we have to remember one time, and I want everyone to pay a little bit attention to these nice Britannica illustrations that summarize the autonomous nervous system. Basically, microscopic dispersed paraganglia, which is responsible for the development of extraadrenal paragangliomas, can be identified in any organs. This is why you do get urinary bladder paraganglioma. This is why you can get primary prostatic paraganglioma. This is why you do get kidneys with paragangliomas. Therefore, the identifications of unequivocal metastases is restricted to lymph node and bone, and the assessment of germline susceptibility is useful when you are dealing with unusual lung. Could this be primary? Yes, primary pulmonary paraganglioma do exist, but this can also be a metastatic disease. And from that perspective, the new classifications emphasize the role of sustentacular cells. In a way, sustentacular cells are benign, non-neoplastic elements in these tumors. If you have a liver biopsy with no sustentacular cells and with no germline disease, this is reassuring that this is a metastatic disease. But the reverse is also possible, because some of the tumors, when they become more aggressive, they start losing their sustentacular cell network. So there are still things that we have to improve, but the new classifications also emphasize how important is the sustentacular cell network assessment when it comes to distinctions of metastatic disease. Another important thing, and this is going to be my last slide, the dynamic risk stratifications in pheochromocytomas and paragangliomas. These are tumors that are evolving in terms of how we are managing them. What we have learned in the past is no longer accurate from certain perspective, because in the old literature, the metastatic disease has been defined by not taking into consideration the germline susceptibility in all cases. For this reason, the dynamic risk stratification is an ongoing process which underscored the role of Ki67, the role of sustentacular cells, and other molecular and immunohistochemical biomarkers. But more importantly, the new classification clearly did not endorse any of the scoring systems such as PASS, GAP, modified, or COPS. But if you want it, feel free to use it. The classification doesn't also discourage you to do that. In summary, the new classifications is about the consolidation of the practice by combining the H&E and also functional needs and the biomarkers, which can be diagnostic and predictive. With this, I would like to recognize all my editor members and also standing members of the 5th editions that were responsible for the completions of this task. Thank you.
Thank you for this outstanding presentation. So I would like to introduce our second speaker, and just to remind you that the questions we'll keep for the end. And we are very fortunate today to have Dr. Peter Sadov with us. So Peter was trained as a physician scientist at the University of Chicago. and his doctoral work utilized transgender mouse models in understanding the effects of thyroid hormones in human pathology, human physiology. Then he pursued a residency training in Brigham and Women's Hospital, which was followed by the subspecialty training in endocrine, genitourinary, and head and neck pathology. So Dr. Sadov is a very passionate teacher. He has published over 200 peer-reviewed papers. And at present, he serves as a director of the head and neck pathology and a subspecialist in GU and endocrine pathology. So just off note, Dr. Sadov is currently the editor-in-chief of the Head and Neck Pathology Journal. So just to emphasize that, we have two excellent experts in this area, and we're incredibly lucky to have them today. And Dr. Sadov will cover common pitfalls in adrenal pathology.
Thank you so much for that very kind introduction. And I want to thank GUPS for giving me the opportunity to present today. And I'm so glad that I'm following Dr. Mehta. I think that typically people don't like to follow people that speak better than they do. But in this particular case, for all of you, especially since for any of you who are eating your lunch while you're watching the presentation, you've gotten through what we can refer to as the business end of the presentation, because Professor Mehta really, he gave you an outstanding overview of the updates in adrenal pathology, and actually, for the most part, every single thing you need to know. And even included in his presentation, you'll see some repeats here. We didn't actually talk before presenting, but a number of the pitfalls for adrenal pathology are in the diagnosis. So I think that was important to talk about. So I have a very, very brief agenda. Maybe I'll even finish quickly, although I do tend to go on a bit. But I wanted to talk to you a bit about the background for adrenal surgical pathology, and then some common pitfalls in diagnosis. So, we use this word very frequently, but we have a number of members of GUPS that are not necessarily American, and English is not necessarily their first language. So you may hear the word pitfall pretty commonly. And I just wanted to let you know what a pitfall is. A pitfall is a pit is a hole in the ground, and the pitfall is falling into that hole in the ground. So for pathologists, these are mistakes that are easily made if you're not aware that they can happen and you do not anticipate them. So this pitfall is just an error that you can make that's unanticipated. And this is what we're going to try to do, is try to help avoid some of these mistakes that, because you can anticipate them. So as a background, I really wanted to step back and talk about endocrine pathology as a field being the first pitfall. So endocrine pathology is an orphan field. And it means, yes, it has a journal. And as you heard, Professor Mehta is the editor-in-chief of that journal. Endocrine pathology has a society within the SCAP, the Endocrine Pathology Society. And it has a diversity of organs throughout the body, rather than a particular, when we think of organ systems like the GI tract, right? But in addition to that, there's a diversity of surgeon types. So there are neurosurgeons who typically deal with pituitary glands. There are endocrine surgeons, which endocrine surgery is a subspecialty of general surgery, so it's a fellowship. These surgeons are typically trained to do primarily thyroid surgery and parathyroid surgery, but also paraganglia and adrenal glands. You have thoracic surgeons who can excise neuroendocrine tumors of the lungs. They may assist some head and neck surgeons and endocrine surgeons with thyroid and parathyroid surgeries, and also may tackle some paraganglia that are paratracheal, etc. Head and neck surgeons, so your ENT surgeons that primarily will focus on thyroid, parathyroid, and paraganglia. Gastrointestinal surgeons that will do pancreas plus intestinal endocrine tumors and paraganglia. And then your general surgeons that can participate in all of the above except for the pituitary. And depending on their practice setting, they may do all of the surgeries or may do very few of the surgeries if they're a general surgeon within a subspecialty practice. So with a diversity of surgeons and of course a diversity of tumor locations, how does one develop an expertise in endocrine pathology? Well, I would argue that most people do not develop an expertise in endocrine pathology, and even self-proclaimed endocrine pathologists, there are likely less than 30 in the entire world. And although I love endocrine pathology, I would not claim myself to be an expert in the sense that there are very few places that actually practice endocrine pathology well. So endocrine pathology as a subspecialty, even in subspecialty practices, is fairly rare given the anatomic diversity of endocrine neoplasias. So for those rare places with endocrine pathology subspecialty, for instance, University of Toronto, where Professor Mehta is, he actually does the whole range of endocrine pathology, everything, pituitary and all the other organs. But that's really, really strange. I'm not saying he's strange, but that idea of that is strange. So not all are created equal. For instance, my colleague, Dr. Barletta at Brigham and Women's, who actually does have a separate subspecialty of endocrine pathology, they do thyroid, parathyroid, and adrenal. So other endocrine tumors of the GI tract go to GI, lung goes to lung, pituitary goes to neuropathology. So even though there is actually a separate endocrine pathology division, it's not all of endocrine pathology. It's a subset of endocrine pathology. So this is pitfall number 2, the surgeons. With the diversity of surgeon types, maintaining an open line of communication allows for the most accurate diagnosis. So surgeons who are not primarily adrenal surgeons may have a more limited knowledge of the diversity of pathology, the location of tumor types, and the ability to communicate that information, what their clinical suspicion is, adrenal hormone levels, what the significance is of imaging studies, Hounsfield units. Maybe some of you have heard of that in terms of uptake in the adrenal gland, in terms of predicting what type of lesion might be present. And of course, most importantly, clinical history. So depending on what your electronic medical record system is, being able to look if preoperative hormone testing's been done, what the preoperative suspicion is for what that adrenal pathology might be, is exceptionally important because the patient's clinical history really tells you so much. And then relationships with other specialists, I like to call pitfall number 3, endocrinologists. So there are general endocrinologists that take care of patients that have endocrinopathies. And of course, there are endocrinologists in the community who practice, who do everything, who do the whole range of things. And then there are endocrinologists who are in a more tertiary setting that may actually focus their practice of endocrinology toward different specific disease types within the overall umbrella of endocrinology. So there are those practitioners that focus on general endocrine neoplasia, if they actually focus on neoplasia at all. Again, if it's a subspecialty practice, there will be only a subset of certain endocrinologists that will actually deal with neoplasias at all, or they'll refer to a colleague. There are those who focus on thyroid, parathyroid, adrenal, and pituitary neoplasias. And there are also some institutions, for instance, one of them is the Moffitt Cancer Center in Tampa, where they don't actually have endocrine oncologists, and the acting endocrine oncologist is an endocrinologist who has a subspecialty interest in endocrine oncology and actually functions in their cancer institute. So it really depends on what the setting is and the practice type. And then you actually have endocrine oncologists, and these are specific endocrine oncologists who deal with malignancies, largely of the thyroid, parathyroid, and adrenal glands. But even in some institutions, the endocrine oncologists are divided. So you have a head and neck oncologist. That's how it is here at Mass General. We have a head and neck oncologist, and our chief of head and neck oncology at Mass General is a thyroid oncologist who deals predominantly with thyroid carcinomas, but also just parathyroid as part of the practice. And then we have genitourinary oncologists that deal with GU as part of their practice, which is, again, fairly rare to have adrenal malignancies, so that there's always very specific people who will deal with the adrenal malignancies, where the most commonly dealt with malignancies in GU oncology, of course, are prostate and kidney, right, and bladder. So those are the main ones, and then you have smaller offsets like penile and testicular and everything else. But the main bread and butter, of course, is prostate cancer. So you'll have somebody among the GU oncologists who also deals with the adrenal glands if your endocrine oncologists or your head and neck oncologists who practice endocrine also don't deal with adrenal glands. So most pathologists see very few adrenal glands unless they're in a subspecialty practice or at a major adrenal tertiary care center. So it really presents a challenge for pathologists, especially in general practice, but even for those that are in subspecialty practice, when they get adrenal glands. Like, what do I do with this adrenal gland? How do I deal with it? Adrenals really are an orphan gland. So where I am, my two practice areas are head and neck pathology and GU pathology. And currently the way it works is that the adrenal glands go to GU pathology, but our GU pathologists aren't people that have particular interest in adrenal glands, and our adrenal surgeons are not our urologists. Our endocrine surgeons do the adrenal surgery. So then, in terms of, when you're in a subspecialty practice, you're typically very familiar with your surgeons. You know them very well. You have their cell phone on your phone, and you text them when you have some question, and they write back in 12 seconds. But if you're somebody who the majority of people you're dealing with don't do adrenal glands, but then you have these adrenal glands that come and you don't know the surgeon very well, then that relationship and the questions you ask and how you phrase it can be very challenging. So it really is this kind of orphan area in pathology. So given I'm the GU pathologist with an interest in adrenals, I typically see every adrenal gland that comes out at Mass General. And my colleagues are very happy to sort of dump them on me, or at a minimum have me write the report and then sign them out. So for adrenal glands, you can have endocrine surgeons, general surgeons, or urologists. But I say here at Mass General, the urologists don't do the adrenal surgeries unless they're actually part of a radical nephrectomy that also is bringing the adrenal gland along with it. So, questions that you want to ask for adrenal pathology, what is your preoperative diagnosis? And oftentimes for adrenal glands, you don't necessarily have a preoperative FNA or preoperative core needle biopsy in terms of diagnosis. There's always these, longstanding concerns about seeding a tract with tumor, et cetera. But typically, if the patient has a known history of lung cancer, your first thought for adrenal mass is metastatic lung cancer, especially if it's bilateral. And Professor Mehta discussed that a little bit. You want to have a notion of what you're going to get. Non-neoplastic adrenal tumors, you start thinking about the hypothalamic pituitary adrenal end organ axis. So does the patient actually have clinical symptoms? Does the patient have elevated serology of one of the adrenal cortical or medullary hormones? And then you have the range of findings that can be benign neoplasias or malignant neoplasias of the cortex, or the uncertain biological potential of tumors of the adrenal medulla. So pitfall number 4 is the gross evaluation of the adrenal gland, right? Because, you start thinking about the adrenal glands weighing between sort of 5 to 10 grams, depending on the size of the person, et cetera. But adrenal gland is surrounded by periadrenal fat. So you want to, keep in context, is the adipose tissue coming with the adrenal gland, or is it dissected off the adrenal gland? And of course, in a situation where you're concerned about malignancy, dissecting fat off of the adrenal gland may also cloud your ability to assess for invasion of the periadrenal soft tissue if you dissect it off. So, you want to describe the appearance of the adrenal gland, and Professor Mehta showed you some very nice examples of gross photographs that you can use to think about how you describe it. Does tumor protrude from the gland into the periadrenal soft tissue? Is the surface of the adrenal smooth, disrupted? What color is it? Is there a solid tumor that's palpated within the gland, and you want to measure it in all 3 dimensions, and you want to describe it. You want to describe what you're seeing particularly well. You want to discuss the relationship of the adrenal gland to the surrounding cortex and medulla. You want to describe patterns of infiltration, vascular invasion grossly that you see, gross invasion of surrounding tissues, and the focality of the lesions. Are there multiple lesions? What does the adrenal gland look like? Professor Mehta showed you the setting of multinodular adrenal cortical disease, right? So if you have a dominant mass, and this is the same thing, you can think of it like the thyroid if it makes it easier for you, where you have thyroid follicular nodular disease, where you have multinodular thyroids with one dominant nodule, but multiple other small nodules. So you can think of the adrenal gland the same way. Remember, he started describing that lesions that are greater than 3 millimeters, the likelihood of it being a clonal lesion is particularly high. So you can have multiclonal lesions present in the adrenal gland. So you can think about it as multinodular adrenal cortical disease with a dominant adenomatous nodule, depending on how it pans out and what the molecular genetics are of any particular tumor type. So don't forget the forest. That's the saying that you have all these trees present there. You may have this very large mass that's there, but what does the rest of the adrenal gland look like? Is there a nodular cortex? What does the medulla look like? You want to make sure you can describe all of that, because missing that part of the pathology can really help you miss the etiology of what's going on for the patient clinically. So you do the gross evaluation, and then the question ends up being frozen section diagnosis. We try to avoid frozen sections for most endocrine tumors, to be honest, but the frozen section diagnosis can be a pitfall because you're presented with a patient that has elevated metanephrines, but at the same time, you end up receiving something that looks like a cortical neoplasm, and you're not really sure. So if you get that, you might want to describe it. So do your gross exam, get a good reason for doing that frozen section, evaluate endocrine neoplasia, which can be really, really challenging because, as most of you know, many endocrine neoplasms, especially in the adrenal gland, are overtly banal looking. They're very, very bland in appearance. This is one of the reasons why you have to evaluate 50 high power fields, or what used to be 50 high power fields, or 10 millimeters square, however you want to define it now. But the reason you need to evaluate so closely for mitotic activity is because endocrine neoplasms are bland. The other issue that arises with endocrine neoplasms is endocrine nuclear atypia, right? You can have some very large cells, some smaller cells, irregular cells, and particularly if you see endocrine nuclear atypia, you're dealing with a benign entity. And usually, or often, the more bland lesions can be the more aggressive lesions if you actually pay close attention. So these are things that are really, really challenging on frozen section. So you can have a differential diagnosis of an unremarkable adrenal gland, adrenal cortical nodular disease. If you can't figure it out, you can say neuroendocrine neoplasm favor pheo. You can say adrenal cortical neoplasm favor adenoma. Or you can just stop short and say adrenal neoplasm pending permanent section. And you should never feel uncomfortable to say, I'm not willing to take the risk on this frozen section. There's definitely a tumor here. You got your tumor out, and we'll evaluate it on permanent section. That way it can be fixed properly. You get a nice picture. You can do whatever you need to do with the adrenal gland without, causing some sort of additional inappropriate surgery to be done. So just to give you one idea, 42-year-old woman. She has a 1-year history of hypertension, not super high, probably my baseline that I currently have of 160s over 110s, slightly hypokalemic. She has an abdominal CT that shows a 4-centimeter right adrenal mass. Her renin, her plasma renin is normal. She has normal AM cortisol. Her aldosterone is at the upper limit of normal, and her urine and plasma metanephrines are normal. And here you can see this is actually a really nice image of, I took this actually when I was a resident at Brigham and Women's, so this is old. But you see this very nice, very nicely defined, well circumscribed mass that's yellow in color. If you look on the superior aspect of that mass, you can see the adjacent adrenal tissue. You can see some slight nodular change. That's what I'm saying. Make sure you look at the entire forest. There's some slight nodular change in the cortex, which is orange. And then you can see that kind of gray area in the middle, which is the medulla, which doesn't seem to be expanded at all, but you can see some slight nodularity to that adjacent adrenal cortex. And this is what it looks like under the microscope. You can see that at low powers, this is a 2x objective, 20x magnification. You can see there's some slight nodularity to that adrenal cortex, and adjacent to this mass that you see here, this adrenal cortical mass that is negative for chromogranin, which you can see in the adjacent adrenal medulla, and positive for other markers. The Ki-67 proliferative index is 6%, which is kind of borderline for an endocrine tumor. And the final diagnosis here is adrenal cortical adenoma with adjacent cortical nodular changes. So Dr. Mehta actually showed you that the new WHO asked if possible to do a CYP11 B2 stain. This is aldosterone synthase immunostain There were very few places in the US that actually had this available. It's becoming more common. When we first started assessing these, we would send them to University of Michigan. Now we have this assay available in-house. This is able to assess for hormone production, allows you to assess the nodule of interest, but also assess the adjacent adrenal cortex. And you saw some really excellent pictures of that, but that's pitfall number 5, which is assessing for hormone functions in tumors, which you don't typically have the ability to do other than now aldosterone. So this is a patient that has a tumor that is diffusely positive for aldosterone synthase. And if you look carefully in the periphery, you can see, on the main specimen, you can see a small cluster in the top left, and you can see adjacent clusters present there. So just sort of, you have aldosterone producing centers outside of the main mass. So the patient actually her follow-up is that she had no recurrence, and her hypertension actually normalized. Then I wanted to show you this additional 1-year-old with a right adrenal mass, 4.2 centimeter mass, which is pretty large for a 1-year-old. And you can see the normal adrenal tissue on the left, and you see the mass on the right. When you see higher power, you see this nodular clustered neuroendocrine tumor that's present here, which of course is diagnostic of a neuroblastoma, poorly differentiated with 1 negative lymph node. Now, I only point this out because this is not a discussion about the diagnosis, but pointing out certain pitfalls, like the errors that you can make. One of the difficulties is trying to figure out something like the mitotic karyorectic index. Now, this is something, this scale that's created by Shimada, who's in California. If you actually read in the textbooks, it's really, really difficult to make this calculation. And what you find is from person to person variability in scoring this, right? And since this is part of actually making the diagnosis about prognosis for these tumors in children, it's particularly sensitive. And so every time I've kind of calculated this index, I subsequently get a phone call from Shimada, who tells me my classification was wrong and that I didn't do it correctly. And then I said, "Did you do it?" He has postdocs who do it. And it's like I don't know anybody who hasn't gotten a call from Shimada telling them they've done this index wrong. So it's really, really difficult to do. And so this is one of the difficulties in this diagnosis, doing this classification system that requires you to do this mitotic karyorectic index. Okay, there is a new publication showing that there's a linear regression model that shows you can calculate the MKI using the Ki-67 proliferative index with this particular calculation. I actually haven't tried it since then, but this is definitely a pitfall, is trying to come up with this calculation of this index. The final one I want to give you before closing out is this right adrenal mass in a 19-year-old. The tumor approximates the surgical margin. That's here. It's an oncocytic tumor that shows tumor necrosis that's present. You also can see some atypical mitotic figures that are present there, but in an otherwise sort of bland lesion. This is inhibin, showing its adrenal cortical lesion. This is the Ki-67, which is 15%, and you can actually see some venous invasion of the tumor that's present with wrapped in endothelial cells present here. So this is actually challenging. It's an adrenal cortical carcinoma, which is low grade, and Dr. Mehta showed you how to do the high grade versus low grade calculation, but oncocytic tumors are really, really challenging. And I said, particularly in this case, the patient's 19 years old. So this is where we have some overlap in our presentations, where for oncocytic tumors, we use this Limb-Weiss-Scaglia scale. And if you start looking at major criteria as greater than 5 mitoses per 50 high power fields, atypical mitotic figures, venous invasion, and then you have minor criteria, the tumor greater than 10 centimeters. In this particular case, it wasn't. Tumor greater than 200 grams. In this case, it was 68 grams. Necrosis, multifocal, which was seen here. Sinusoidal invasion, which was seen here. Capsular invasion likely, but a little bit difficult to assess. So this patient's positive for cortical carcinoma. But then it's like this patient is, young. So then you have the Weineke criteria, which is for patients that are up to 20 years old, right? So this patient's kind of at the borderline of being a pediatric patient versus being an adult patient. And the Weineke criteria are somewhat different. With children, they actually are allowed to have things that might be more worrisome in adult, but like children often have more mitotically active tumors. Children tend to have more cellular tumors. And there's a certain amount of flexibility that's given in pediatric cases that if it was an adult case, may be called cancer, but in a child might be called borderline in a tumor. And a child, like, when someone's 19 years old, that's kind of very much at the junction of a child and an adult. So in this particular case, it satisfied both sets of criteria, but can be very, very challenging. And I make this point because if you do not receive these types of cases particularly often, and you get an oncocytic neoplasm that doesn't seem to fit super well with what you have an idea of what your impression is for a malignancy, it can create some issues. Oscar mentioned the Weiss criteria. Again, some of these diffuse architecture, clear cells, some of these criteria are somewhat subjective and a little bit, not approachable by people to be able to figure out the criteria. So actually, the one thing he mentioned and showed beautiful photographs of is the reticulin algorithm. And reticulin is particularly strikingly helpful in making the diagnosis of malignancy in adrenal cortical neoplasias. Loss of that reticulin network is super, super helpful. And I encourage, and everybody has this, Dana, and I encourage you to use it if you have any question whatsoever. And then the secondary tumors, which can be pitfall number 8 that you see in all, is metastasis, primary lymphoma. What is the patient's history? You must know the patient's history in order to be able to not get yourself stuck thinking you have an adrenal cortical tumor when it's actually a metastasis. So knowing the patient's history is exceptionally helpful for making sure you don't fall down the pathway of making a misdiagnosis. So in conclusion, if you approach an adrenal gland with knowledge of the clinical information for surgery, including preoperative serologies if it's an adrenal primary, the patient history, including other cancers, and an awareness that the findings may not be what you initially expect based on the clinical history that's provided to you, you can be saved. If you understand that the classification systems can be very, very challenging, and you have to be honest about your ability to work through them. And sometimes if they're really challenging, in the case is borderline, don't be afraid to be descriptive and say that this is a borderline lesion. If it's not obvious it's a cancer, then don't call it cancer. If it's not obvious if it's benign, don't call it benign, because these things, as Dr. Mehta showed, these can metastasize 20 years later. They can metastasize 30 years later. If the patient's 18 years old, that patient's going to likely live long enough to suffer those consequences. So if it's a borderline tumor, mention its borderline features and say why you feel like it's borderline. So just try to avoid these pitfalls because we can. So in summary, thank you very much for your time. This is currently what it looks like outside of my window from my office at Mass Eye and Ear in Boston. This is the Charles River. It is partially frozen, so you can see the breaks in the water, but this is like a picture perfect, even though it's kind of sunny out. It looks just like that now. So anyway, thank you for your attention, and hopefully we can tackle some of these challenges together. And with that, I shut up.
Thank you. That's an excellent presentation. I wanted to add a pitfall number 9 from my, I really like how you describe these different, surgeons you deal with. So the other one is a transplant surgeon. I've been fried this whole morning by a transplant surgeon because there was a transplant kidney with small lesion, and I thought it's going to be an ectopic adrenal next case. But on the frozen, it was extremely challenging to my surprise. So we have to put the organ on hold and wait for the rush biopsy to make sure that this is in fact an ectopic adrenal, not a renal cell carcinoma.
Absolutely.
So, yeah. So, Sunak, do you want to lead with the questions? We do have a few questions.
Yeah, and before getting into some of the questions that are coming in, I just want to tell all of our viewers that if you have any questions, just type them into the Q&A box, and we'll direct them to Dr. Mehta and Dr. Sado. One of the first questions that I wanted to get to is from an anonymous attendee, and their question is for pheochromocytomas, paragangliomas, and I think this is true of a lot of centers where we will do immunohistochemistry for STHP, which is widely available. And the question is, how far do we go? Dr. Mehta, Dr. Sado, if either of you want to tackle this, what is your panel for working up a routine case? Do you add on things like FH2SC and CA9 on a routine basis? What's your approach and what's your recommendation?
Do you want me to start, Peter, or? So in my clinical practice, I always read the clinical history. Let's assume that you are dealing with an adrenal pheochromocytoma, intraadrenal. Most of these patients will have a good biochemical history, for which the 24 hours urine or serum-free and metabolite of catecholamines, which includes for dopamine 3-methoxytyramine, for noradrenaline, norepinephrine, and adrenaline, methanephrine levels will be present. If you are dealing with a surgical specimen from a patient that has methanephrine elevations or adrenaline elevations, you don't need to do by default ACTH immunohistochemistry because they will never be ACTH deficient. That's number one. So basically, if you are dealing with an extra-adrenal location where a surprise diagnosis may come, such as I see so many urinary bladder paragangliomas, none of them undergoes for routine catecholamine testing. So you have no idea about the potential cluster or genotype, phenotype correlations with respect to biochemistry. In that case, yes, routine testing for HTHB is required for extra-adrenal paragangliomas. In head and neck region, for those who are practicing other things, it is a requirement because 1 of 2 head and neck paraganglioma has HTH deficiency. These are the things that we consider. In my panel, I don't do routinely FH or 2-6-enol cysteine immunohistochemistry, but I add alpha inhibin and carbonic anhydrase as a part of my routine adrenal workup and also extra-adrenal. I am not required to do, it's a desirable approach and depends on your resources. Sometimes you have a scanty tissue, which you don't want to waste your tissue. You do HDHB immunohistochemistry if you don't know it. But you can do stepwise approach. After you confirm the diagnosis of paraganglioma or pheochromocytoma, and you, depending on your knowledge on the preoperative biochemical phenotype of your patient, you can add more of these if your HTH comes as normal with no deficiency. And at the same time, as the standard of care, all patients with this diagnosis, in theory, should undergo germline testing. So you should know how your practice setup is in your institution or the referral institution that is sending you in this case. And you have to communicate with your treating physician saying that if you are not going to do this, I'm going to add some of the additional markers. But the routine use of carbonic anhydrase and alpha inhibin is not justified, but it is a desirable approach. Routine use of HTH is required for extra-adrenal paraganglioma, and especially when you don't have adrenaline excess, it is required regardless of the anatomic location. And whenever you have a germline testing that shows variant of uncertain significance, for example, for FH, do FH and 2SC immunohistochemistry because you can add value. Whenever you have a patient that has a variant of uncertain significance or tiers 3 variants, and if you have the tools, do it. That's very useful. For example, I'll give an example of a VHL patient which had the typical VHL pheo history, morphology, typical carbonic anhydrase, typical alpha inhibin, and VHL patients can have attenuated, very dusty looking, reduced but not absent HTH expression as well. And the patient had pure noradrenergic phenotype. Germline testing shows nothing. You have to also challenge your genetic lab saying that how sensitive is your detection? So then after I challenged them, they went to do an assessment and we found VHL germline mosaicism. So things are not that simple. We have to adopt a dynamic process. Therefore, my advice depends on what you see, what you have, what the clinical question, and how you can help to the patient and the clinical team. With this, I will leave to Peter if he wants to add anything extra.
I don't really think anybody can add anything to that. But just to say, our practice is we typically we do SDH as a reflex, and then we for all paraganglia, and we typically, even though it's not indicated, we typically also do it in all pheos. So we do SDH reflexively, and the other stains that Oscar mentioned, we have them and we do them if we have any clinical suspicion. We add them in. We don't standardly do CA9 in any of them. You know, at baseline, but we'll add it if it seems to be necessary.
And the other thing is, if I may, beyond the molecular immunohistochemistry, do Ki-67 in all paragangliomas and pheochromocytoma. This is an essential requirement. This is very important to distinguish low proliferative disease from the high proliferative disease, and it has a prognostic implication. This is one of the things that we want everyone to come to the same level. Ki-67 should be standardly performed. Although my Ki-67 counting may be different than others, but if you use automated or if you do manual counting from hotspots, then the variations between user is not going to be huge. Therefore, this is what the EARC is also, the WHO classification is also recommending. For any Ki-67, it has to be no more eyeballing, please.
Yeah, and it's both Ki-67 and SDH are part of the MGAP criteria if you want to follow that, because it's pretty easy to and straightforward to follow. So we have some other questions. So the question that I wanted to pick is about differentiating eosinophilic change associated with adrenocortical carcinoma from an oncocytic tumor. What is the criteria to distinguish them?
Shall I do, or Peter, do you want to do it?
I let you do everything. Go.
Oh my, okay, I'm on the hot seat right now.
Yeah.
Okay, so my approach, at least the way that I do, is compact cells or lipid-poor adrenocortical cells don't have the same cytomorphological features of oncocytic cells. If you think about the same phenomenon exists in thyroid pathology, some of the thyroid follicular cells, or even in thyroid, they can have a little bit eosinophilia. Not every single eosinophilic change in the cell cytoplasm means that this is an oncocytic change. So number one, at the morphological level, I want to see large cytoplasm, which has granular cytoplasmic appearance. If you have a good section and good tissue fixation and processing, you can see that one. They are full of mitochondria. Number two, I really would like to see prominent cherry macronucleoli, which is very useful. You don't get this in compact cell morphology. Yes, there are few situations in which you will have compact cells admixed with oncocytic cells, but we want exclusive oncocytic change to call an adrenocortical neoplasm as oncocytic type or oncocytic subtype. Number two, if you are lucky and if you have access to anti-mitochondrial antibody, the staining will help you, similar to oncocytic renal epithelial neoplasms. You will get an abundant mitochondria, whereas compact cells will not show that much mitochondrial distribution. It will be more sparsely. So basically, histochemistry, cytomorphological assessment is very useful. And the second thing is if you have access to anti-mitochondrial antibody, that is also useful. This is how I do in my cases, but I would like to hear if Peter has different approach to this distinction.
We only use the morphology.
Yes.
Yeah.
That's certainly a difficult area. And looking at the questions, we do have quite a few on immunohistochemistry. There's another one from Dr. Sean Williamson who brings up perhaps patients who may not have consented to germline testing, and then they get results of, let's say, STHB immunohistochemistry results, FH or 2SC immunohistochemistry results. Have you gotten any pushback on doing these stains in terms of the germline implications, and just for broad awareness for somebody that may be listening in?
I think Canada and US is a little bit different. So this, I would refer to certain things to the US practice system, so which I'm not familiar. But in Canadian health system, it's a social health system, and patients don't pay anything, and they are giving consent for their treatment as well. And it's part of the request to do germline or any testing in their tumors, unless they oppose to have certain things up front. So if we have some patients, they don't want to have even some assessment on certain things. That's a separate issue. But we are, as a physicians, we should advocate and communicate with our patients. But from a legal perspective, I don't know how the US practice law differ from provinces to other provinces, but I'm sure there should be a way of implementing things as the standard of care.
Yeah, we do it, and we actually haven't had any pushback from patients. I think probably it's an issue of red states and blue states at this point. Red states don't want it, and blue states do it. No, I'm saying, but the truth is that we use it and we say it's a screen. So typically, if we have a loss of expression, then we will say that loss of expression may indicate
Exactly.
a germline mutation. That genetic correlation is recommended. And at that point in time, then the clinical person will have the opportunity to consent the patient for germline testing if they want. And if they don't want it, then this is not considered to be diagnostic of a germline mutation. It's indicative of a possible germline mutation. So if we've gotten zero negative feedback from this case, in these cases, and we leave it up to our clinical colleagues that are interacting with the patient to consent them for follow-up. But for instance, our endocrine clinics all have genetic counselors available. So they go to the genetics clinic, or they're recommended to go to the genetics clinic if we have these findings. And then it's up to the patient whether or not they want to pursue it or not pursue it. But they're given the option whether or not they'd like to.
And I think that we have 1 minute for a short question. So this is about the renal fusion. How often do you see it in your practice? So it's kind of pertinent to my scenario this morning.
So it's not a common, so adrenal to renal fusion is rare than right-sided adrenal hepatic fusions. So hepatic and adrenal fusions are very frequent and also a challenge for the staging, because sometimes the tumor at the naked eye can simulate like invading the adjacent liver, but it's not actually, because the whole area is almost like a hamartoma and organized in a different way. And this is a distinction. However, renal to adrenal fusions are not so common in surgical practice. I do see several adrenalectomies. I will say it's not even 1 in 100 adrenalectomy specimens that we do see for completely excised specimen. But I do see as well more and more sellated adrenalectomy, so which I can't give a true percentage, because retroperitoneal adrenalectomy specimen comes like a curating material, and it's a very difficult challenge to diagnose them, to distinguish a malignancy. But this is how we do get several ACCs done in a year. This is a growing concern from a practice point, but potentially not the platform to discuss too.
Yeah.
So
What's your experience with the fusions?
I've had basically 3. The answer is I've had 3, 10, 20 years, I guess. Okay. Yeah.
Less.
You have 1 today.
Right. Yeah, I have 5 total.
Yeah.
So I think we're getting to the end of our time slot. And once again, I really want to thank Dr. Mehta and Dr. Sado for wonderful talks. I think, as Dr. Sado pointed out, these are rare specimens, rare tumor types that we don't encounter on a daily basis, and it's always a challenge. And thank you for 2 excellent talks that helps us navigate this. And this recording will be available on the GUPS website for everybody to refer to later. So once again, thank you to our speakers.
Thank you for having us today.
Thank you.
Bye-bye.
Thanks.
Bye-bye. Have a wonderful day. Bye-bye.